Through which enzyme system is Ritalin metabolized?
Is that Solid Snake?
Oh. Colonel, through which enzyme system is methylphenidate Ritalin metabolized? Hello,
we're not...
everybody. We're doing board review today, except it's not my board review. It's Psych board review.
Yeah.
I'm joined today by Lev, if you want to introduce yourself.
Hey everyone, I'm Lev. Relevant to today's conversation, I'm a psychiatrist in my daily life. And yeah, I stream and stuff. The funny thing about what you just said, though, is that because of the attitude people typically have about psychiatrists, I just unconsciously insert the word unfortunately at the end of everything that you said. Like,
Okay.
I have to deal with psychiatry in the hospital, unfortunately. Our patients often have psychiatric issues, unfortunately. That's my unconscious bias. Dart quiz. Okay.
Oh boy. All right. Here we go.
Mr. Black is a terrible example name. What the fuck?
Mr. Black.
My bestest buddy in the whole wide world. Mr. Black.
Mr. Black is a 75-year-old man who is a resident of a retirement community. Oh, so you know he's getting some. Do you guys also have the thing with like the epidemic in nursing homes where like everybody's coming in with syphilis in their 80s?
Yes.
Over the past few years, the staff at the facility have become more concerned for his health. He is withdrawn, speaks softly, and is overly cautious when he moves. All right, he's not getting so. His once lively expressions have dissipated. Now he rarely shows any emotional expression. That would be called flat faces. At times, he appears frozen, not smiling, blinking, even for several seconds when someone calls his name. He was recently placed on fall precautions after many stumbles in the hallway. One nurse had noticed some unexpected involuntary movements at rest. A dietitian noticed his weight loss after he stops eating the majority of his meals. Social workers said when he went to sign some forms, his handwriting had become quite small and somewhat illegible. Social worker is also growing concerned that he may not be able to make financial decisions appropriately. What is his most likely diagnosis? Okay, so gut instinct. I mean, I'm worried about Parkinson's. Because of like insidious onset, flat faces. I'm worried about tremulous activity, involuntary motions, and like scribbling, illegible handwriting, and then that frontotemporal dementia, or he's not able to make financial decisions appropriately. Yeah, so I would be in between like Parkinson's and Alzheimer's here. What's the psychiatrist's opinion?
I think similarly, right? Like this is the thing I always have to remember with tests is like don't assume stuff that isn't in the STEM. So it's like it's probably not actually something more psychiatric because like does anyone develop a new psychiatric disease at 75 years old? Probably not. And then yeah, like insidious means that it like has like a slower onset over like a more chronic time period. Just if no one know, it doesn't mean dangerous, which is what I thought as a med student when people said insidious. He has like micrographia, which is like writing very small.
That's a psych word. Micrographia. Actually, that might be a neurology word.
Micrographia. Yeah, it's like thing.
Or it's like what's the thing when it's like you can't feel a thing? Tactile agnosia.
That makes sense. Yeah.
Astriagnosis. It is always Greek, dude.
Yeah.
Astriagnosis.
Yeah, that makes sense because agnosia is like unable to recognize faces is what prosopagnosia. Yeah.
I know that because of a visual novel.
Okay, yeah. So I think we all agree Parkinson's. It would be really embarrassing if this isn't the right answer. Oh, okay, don't display this message again. Yay!
I have a 100% win rate. All right. A patient who is treated with lithium develops acute toxicity. Which of the following is true? Lithium is contraindicated in patients with all cardiac diseases. Lithium has a high therapeutic index. Overlap may exist between the GI symptoms of lithium toxicity and standard GI adverse effects. Lithium has a characteristic discontinuation syndrome. Thyroid and renal function changes occur early in lithium therapy. Okay, lithium, I'm worried about renal toxicity, right? Lithium has a low therapeutic index, which is why I don't with lithium. I've never prescribed lithium in my life before.
Unfortunately, it's extremely effective for bipolar disorder. And like there's some things that nothing works except for lithium, which it's unfortunate because I also hate lithium.
What does that even have to do? Atria? Is it biatrial enlargement?
It's atrialization.
Atrialization. It had to do something with atria.
Yeah.
All right. Well, I just said like the 4 or 5 things that I know about lithium, and I don't think any of these really are in the answer choices. I think
Well, you
it's
you
not
got
B.
this.
All right,
Yeah,
I know for a fact it's not B.
Mhm.
I think E maybe, unless it's like early in lithium therapy is like the buzzword there. Like maybe the kidney injury only occurs late in lithium. Like I don't know. Like I don't with lithium, so I don't know any of these like side effects.
Is that your guess? Is that your final
I'm gonna
answer?
say E. Yeah. What's
Okay.
the psychiatrist's opinion?
Well, wait, I want to check it first because I'm curious. Yeah, I'm pretty sure that you're right. That it's not early. I guess
It's
it could
late.
happen early. It's usually after.
It's
you've been
more
on
like
lithium for a
usually
while.
it's like if the psychiatrist wants to start lithium, it's contraindicated in CKD. But it's like I don't know if that means it happened early or late.
Yeah, it's usually in my experience, and also I'm just gonna guess probably in the literature like late, like you've been on it for a while. Like you'll check the thyroid and the kidney function among other things before you start, and then you'll keep checking it every so often. But it's not like clozapine or something where you're going to be checking labs like every week or every other week for a little while. It's like on the order of more,
Clozapine,
like,
you're
months
worried
to
about
years.
agranulocytosis.
Yes, except REMS
Oh.
doesn't exist anymore, so we don't have to do that.
Oh. What the is this question? Dude, this is like the history of asylums in America question.
A large proportion of our questions are like this.
Maybe we have questions like what is the second most like common cancer in like males in
That makes
America
sense.
or something. But like that's like a normal question, but like you're never going to see like what ethnic group? I don't know.
This feels like a trap.
Dude, like because you know like people are going to say indigenous people males and then the answer is going to be white males. But then it's just like how ingrained in racism / historical outdatism is the American
This
Board of
test.
Psychiatry and Neurology. Are they really going to let you say like indigenous people males smoke more than white males? Like there's no way. Dude, put down D. Put down D.
I feel like we have to go there first.
No way. No way. Wait, put down B.
Huh?
That is fucked up. That is why the fuck is this on your boards, dude?
That's a good question. That's a good question.
Sagittarius says, please show the explanation. Oh, bro, 17% of people are with us.
17% of people are woke.
30-year-old indigenous people males and females have the highest smoking rate among U.S. adults. The report, Cigarette Smoking Among Adults, U.S. 2004, reveals
2004.
What the reveals that with the exception of American Indians, Alaska Natives, women in each ethnic group are less likely to smoke than their male counterparts. Smoking is also becoming increasingly concentrated among people at lower income and educational levels.
This doesn't
Dude,
explain the
This
answer.
doesn't explain anything. Also, you can tell it's 2004 because vaping is not part of the conversation at all.
Yeah.
Oh, whoa. Okay, this is actually like a medical question. Okay,
Yes.
which of this statement is correct regarding tricyclic antidepressants? Most secondary amines have a higher affinity for blocking serotonin reuptake than norepinephrine. Dude, you can tell me that's like correct or incorrect and I would believe you no matter what. TCAs have a negligible effect on QT interval. Okay, well, I know that one's wrong already. Overdose with TCAs can be lethal due to cardiac arrhythmias. Well, I feel like B and C contradict each other, so... And I know B is wrong, so... TCAs
Oh my God,
have a
this
more
is-
robust response than stimulants for ADHD treatment, and E, more recently, TCA use has increased. Yeah, so... I feel
This
like...
is so random.
What the One, I really never see people on TCAs that much either.
Mm-hmm.
And like more often than not, if somebody has a TCA on their med rec, I'm usually discontinuing it because of QT prolongation on an EKG obtained in the ER. So anyway, I'm gonna say C.
Yeah, I would agree. TCAs are a kind of antidepressant. This, I don't know what to do with this. This doesn't make sense. QT interval, it's like it's a heart thing. It's your heart arrhythmia, your heart rhythm go bad if you too much TCA. So, that's why C is true. This is like so not true that it's hilarious. Like stimulants for ADHD are the most effective treatment that we have in psychiatry, basically. Like the most. So, yeah. And then this is also extremely untrue. Once we invented SSRIs, we never used TCAs again. Perfect. Beautiful. Yes.
85%.
Ooh. Yeah, they have a high overdose risk. You would treat it with bicarb
An adult patient presents for their first visit for anxiety. They describe feeling tense and anxious, stating that they only feel relief when shopping. The patient later reveals that they sometimes pocket small items during their shopping trips. They're ashamed of this behavior and then state that they don't even need the items, stating that they only feel relief when shopping. The patient later reveals that they sometimes pocket small items during their shopping trips. They're ashamed of this behavior and then state that they don't even need the items that they have taken. During the theft, however, they feel elated. Which of the following medications can be used to treat this disorder? So it's ego dystonic, right? That's a psychiatry word. You like that? You like that?
Yeah, good job.
Right. The patient recognizes that their compulsion is like detractive to their daily life. So in a question of OCD versus OCPD.
Ah, yes, that is the classic thing.
Oh, which one is ego dystonic? OCPD is ego syntonic? Okay, there we go.
Yeah.
Anyway, this would be SSRI for the compulsions.
So we're going Prozac?
Yes. Yay!
I think what they're actually going for, is kleptomania.
Oh, this actually is kleptomania.
Yeah.
But they don't like, they feel relief when shopping, not when stealing. I don't know, whatever. It says during the theft they feel elated. But they also say they only feel relief from their anxiety when shopping. That's why I didn't think it was actually like kleptomania.
Yeah, it's like stealing, but also like just the obtaining of things, you know?
Even if you're like buying things, that's still kleptomania?
I think you do need to be stealing things, but it's like, I think part of the larger presentation, phenomenology is like this weird, like compulsive need to accumulate things.
Oh.
They don't actually really like stealing things. That's like the interesting thing about kleptomania. It's basically a variant of OCD.
That's what I was taught. Like kleptomania is like a specific like subtype of OCD. That's why I didn't like call it kleptomania like immediately.
Yeah.
That's why I was splitting into like ego syntonic, ego dystonic.
Yeah. No, that makes sense.
I got honors in psych. It was my one honors.
Wait, really?
Yeah, dude. Go back to the Q Pank and give some hard ones.
Okay. New custom, tutor, hard, only, and we'll do like 5.
A 77-year-old patient presents for evaluation after a minor fall at home. They state they tripped over an uneven carpet and narrowly missed hitting their head on the table as they fell. While they were not severely injured, the patient is anxious about falling again. On physical examination, there's mild weakness in both legs. The patient has difficulty standing from a seated position, walking across the room and returning to a chair and sit. Which of the following interventions can reduce the patient's risk of falls? So that's like a timed up and go test, right? And they have
they're
mild
77
weakness in both legs, and they're 77. How do you reduce the risk of falls? I mean, I feel like
education
about fall prevention, right? Like it shouldn't be that complicated, unless the answer is like C. I'm gonna say it's gonna be like C or E, right? Because like I feel like fall prevention makes the most sense, but vision correction is the simplest. Oh
no, what
is it?
Exercise?
B? Oh my god.
Okay.
Oh my god, somebody redeemed my Solid Snake redeem. Okay, I have to read the next question like Solid Snake. Patient education has not been proven to improve the risk rate of falls. That is not true because we do it in the hospital all the fucking time.
This is not true because like often they tripped over an uneven carpet. You know what patient education helps with? Get rid of the uneven carpets and random cords and things that you could trip over.
Yeah, exactly.
Make the light better. Make sure there's nothing you can trip over. Make sure things that you can see. Make sure that you have things that you can hold on to. And so like that doesn't help.
And then like vision correction, right? Because like you don't know how bad their vision is. What if their vision was bad? That's like one of those things where it's like you don't even think it's like a medical issue, and then you like look at their eyes and they're like -10 in both eyes or something, and you're like, oh, that explains it.
Yeah, but a large meta-analysis found that vision correction did not reduce the overall risk of falls. So what then?
Oh my god. Yeah, take this 77-year-old grandma to the gym, dude. Yeah, exercise her. Through which enzyme system is Ritalin metabolized?
Is that Solid Snake?
Oh,
Colonel. Through which enzyme system is methylphenidate Ritalin metabolized? CYP2D6, CYP2C19, CYP2C9, CYP450, CES1A1.
Actually, I think it is E, unit. I think it is E because like the other one, the CYP systems are all like together, right? And I know for a fact that Ritalin is not CYP inhibited because there's no like grapefruit juice warning with it, right? So DARPA chief. It's not E. Oh, CYP2D6. I'm
pretty sure.
A.
I think it's A too. Oh no, it's not.
It's not CYP 450. I know for sure it's not CYP 450 because that's
TC9?
CYP 450 is sick faces, calm, and crap GPS induce me to madness or whatever.
This one, we think?
I don't know. I don't even know what 2C9. Dude, it's definitely E. It's definitely E because it has nothing to do with the CYP system. You Spectral. This is why I'm the attending. Okay, this is An adolescent begins to experiment with drugs and alcohol despite her fear of these substances. What best describes this behavior? Denial, splitting, acting out, regression, counterphobia. I mean, I feel like by definition it's counterphobia, right? Because like she's afraid of it, but she's doing it, right? Okay, that was an English question right there.
Why this is hard?
I mean, it could be acting out though, right? Because it's like why is she experimenting with drugs and alcohol? Let's examine that.
Well, in psych, I think that I'm just gonna it's a little different from like acting out in what we mean normally, you know, where we're like, oh, this person's like frustrated, so they're gonna, you know, it's like it's specifically, expression of unconscious conflicts in a setting other than the one in which they initially arose. I don't know. Counterphobia is weird though. We don't usually talk about that. I would honestly call this more like, what's it called? Reaction
Exposure.
formation.
Oh, reaction for that's a psych word. Oh.
Yeah, denial is obvious. Splitting is when you're like, it's all good or all bad. Regression is, like age regression. You get more immature. Cool. Well, we got one right.
Yeah.
Oh.
A patient with opiate use disorder and alcohol use disorder is treated with naltrexone and acamprosate, which is correct regarding acamprosate. Acamprosate is extensively protein bound. Acamprosate levels increase when given naltrexone. Acamprosate levels increase following co-administration with food. Acamprosate has a high oral bioavailability. Acamprosate's pharmacokinetics are significantly affected by alcohol and benzos. I don't know if I like this.
Yeah,
okay,
me neither.
So what is acamprosate? It's a GABA thing, right?
Mm-hmm.
And then naltrexone's a partial agonist.
Mm-hmm. Opioid.
Right. Yeah. That's all I got for you. That's all I got.
Okay, so basically for this, this is crazy because it's like, I don't know, I've never seen someone on both of these meds. That doesn't make any
because
sense.
you can use naltrexone for both.
Yes, you can use naltrexone.
Yeah, you
for
can
both.
use naltrexone for both. You should use naltrexone
Actually,
for both. Yeah,
it works better.
Yeah.
Naltrexone is just good for a lot of like substance use disorders. It works really well. You take it once a day. It's usually pretty well tolerated. It also comes in a form where you get an injection once a month, and it lasts for 30 days, so you don't even need to remember to take the med every day. It's really good. I really like it. Acamprosate, horrible. Never seen it work. Sorry, I shouldn't say that.
Oh, damn.
Acamprosate is really hard to use because for one reason, you have to take it 3 times a day. And taking anything 3 times a day is annoying, and no one actually ends up doing it. The other reason is the dosage is 666 milligrams, and do not ask me why.
Not even 667? Because I know
666.
Like Foslo is dosed at 667. 667.
Of course, that happened at some point during this stream. But yes, Acamprosate, 666, 3 times a day is.
You think it's not given together because they interact with each other? So like B is the correct answer, right? Because it's like all of these other things could possibly be true, but acamprosate levels increase when given naltrexone, probably because it's like inhibited or something. So it's like that's why you don't see them prescribed together.
I don't know, maybe, sure.
Dude, this is how I answer. This is how I answer test questions, dude.
Yeah,
it's like you don't necessarily know the right answer, but the way that they give you the multiple choice questions is like, oh, these things can't all be true. So like if they contradict each other, one of them has to be wrong.
This happens all the time. Like seriously, I feel like probably 30% of my score on any given multiple choice test is just from like a 2-hour course I took once on test taking strategies. You know, it's like not even like I know the answer. I'm just like, I just kind of know how this should go.
I haven't picked A in a while. It's probably A.
Well, no, it's like, well, I know this isn't true, and I know that isn't true, and blah, blah, blah. Or like, oh, they actually answered this question in an earlier question, so let me go back.
Oh,
but it's crazy. Yeah, I could not imagine doing that.
Thanks for the fun psychiatry conversation. Thanks, guys, for stopping by.
Thank you guys for stopping by.
I learned so much.
Yeah, this was so much fun. I was actually like really nervous, but also very excited. I always try to tell myself, I'm not anxious, I'm just excited. So I was very excited.
Yeah, and then I was like, why are you nervous? I'm answering the psych questions. It's not like I'm making you answer the internal medicine questions.
Actually, yeah, we should do it the other way around if you still have...
That sounds mean.
access
I don't have
to-
access. I mean, I guess we can do like the free ones, maybe.
Yeah. Okay, sounds good. We should do this again sometime. It was a lot of fun.
Yeah.
I'm always available. Blah, 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 blah. Thank you so much for doing this with
No
me.
problem.
Okay,
All
boy.
right. Goodbye, everyone.